Welcome everyone to our June PDAB webinar. Um, and we are very excited. Today we had a little change in our program. And so you'll notice that there are two of us instead of three. And it's my pleasure to have Jen Laws with us. Jen is the executive director and or is it president and CEO,
It is
Jen?
president and CEO. It's always really weird to say that, you know?
Of the community. Uh, Man, I'm sorry, I'm having a really challenge this morning. The Community Access National Network. And Jen has been very kind with us and very available to be on our PDAB webinar since the very beginning. And I appreciate his participation and the participation of his organization in this really important issue. And so we're going to get a little bit of time where Jen and I can actually talk back and forth about some of the issues. This will give us an opportunity to dive into some of the areas that particularly will be important moving into 2025. I think from the conversation, you'll notice that a lot of our thinking now is preparatory for 2025 and how do we move into that arena utilizing the remainder of this year as a platform and an opportunity for us to develop the issues, develop some of the strategic sense of direction, and then move it forward. And so I'm actually really excited to engage with Jen on that and to really talk in substance about some of these issues. That being said, because we are both smaller in terms of our panel, as well as a number of our attendees, I know this being the week before the July 4th break, a lot of folks were traveling this week. And so I really would like to have this be a little bit more interactive. So please feel free to use the chat tools to ask questions, to make comments. We appreciate those and we appreciate that interaction. We get a lot out of the things that attendees really share with us. And it gives us a chance to respond to them and talk about them a little bit more interactively. And so please feel free to jump in, share your thoughts, ask us questions. And Jen, I look forward to the next hour together, really talking about some of these key issues and how we move this forward and how we move it forward in a way that really, at the end of the day, helps patient access. So we did a few updates, and Jen, we'll go into the updates, but I really wanted to talk about them as we are discussing or going through them. As you know, Colorado is still in the middle of their process, and they're continuing to move forward. Of course, Enbrel has some rulemaking meetings coming up later this fall. And there is a lot of work ongoing with ultimately some votes in the October timeframe. I wanted to really talk about that a little bit, Jen, if we could. You notice we went from rare disease, small patients, higher cost, and we ended up going into a little bit more widely used product, but at a fraction of the cost. I wanted to really get some of your views about that and really talk about what we think is the end game with Colorado. Where are they really trying to take this in terms of looking at products and looking at affordability? Is it really affordability for the patient? Is it out-of-pocket costs? What are they really trying to get at in this process at this point?
Well, so in terms of what they're evaluating and what their ultimate goals are, I don't think they're the same thing. And part of what Ken's really kind of tried to hit home on, as we've engaged periodically, is that there's a giant conflation between PBM profitability and patient affordability. Because there's this idea that if PBMs are making money, they're going to charge patients less. But there's no actual evidence to produce that, right? Like there is nothing that tells us that's true. And indeed, there's really good data that shows us it's not true, especially as the federal government and even various states are investigating PBM activities and behavior. But that's ultimately the core issue as to what's going on here, in part because of how a UPL works, right? If you reduce the reimbursement rate, but not anything else in that, all you're doing is reducing what PBMs put out for medication, not
Right,
what
right.
they're bringing in. It's an increase in profit margin for them.
Yeah,
And
That's,
go ahead.
go ahead, Jen. Sorry.
One of the pieces there that the Colorado Association of Health Plans pointed out is that they're the health plans, right? They're not the PBMs. Sometimes they're the same, they're associated entities and whatnot with the larger health plans. But for the smaller ones, they're not the same, and they can't dictate anything to the PBMs about pass through of any savings that might be realized under a UPL. However, because of the statutory structure in Colorado, the plans are responsible for that. So they've
Right,
come out against this going, we can't do what you're asking us to do. Like it's not a thing. So
right.
that's part of the problem.
Yeah, it seems to me that, you've got a desire to lower the cost, but then you've got an actuarial product that is done using an entire different methodology, entire different goals, and even benefit design varies from, product to product, company to company. And so there's a lot of things that really don't connect in the PDAB world to ultimately allow the patient to benefit from that lower UPL.
Right. And they're trying to move the needle on what the actual goal of a PDAB and a UPL might be from patient benefit of any kind that may or may not be realized to system benefit, because we've been able to consistently, and I say we, and I want that to not just be limited to CAN, right? I want folks to understand that there's a giant group of advocates engaged here, not just based on their own health condition, but on the idea and principle that this isn't going to be beneficial, right? So what we've been able to point out is that there's no mandate, there's no meaningful mandate in the legislation or even the powers that are granted under the legislation to benefit patients. So now they're trying to change the rhetoric to go, okay, we can benefit the system this way. And that really kind of depersonalizes things. It makes things really kind of hazy. What do you mean by the system? Is it the state? Is it the ecosystem of care, dollar flow? Like, what do you mean by the system?
And that's
So
a really good question, Jen, because you and I had talked about this before. If you end up with a UPL that disrupts, for example, the Medicaid rebate and best price, disrupts 340B. And there are a lot of services that are provided around 340B, particularly, for example, the hemophilia community. Are you saving the system money? Or are you potentially reducing access and cost shifting and sending patients elsewhere for some of the care and some of the other things? And with regard to Medicaid, potentially if you shrink the size of those rebates, and again, Medicaid programs do rely on those rebates. What have you done in terms of patient access?
right. Well, and it's not just reducing Medicaid rebates. So we're seeing this with the COVID unwinding, because there's still states that are doing their unwinding, right? So they're reducing how much they're kicking people off of the program and things like that, which is reducing how much money they spend, which also reduces the amount of money they get from the federal government on matching dollars. And now they've got fewer dollars to serve the patients they still have left, and the systems that are contracted to still have left. So when you reduce that reimbursement rate, you're reducing the dollars in the system. And this is something that I think is really, really important, especially as we look at marginalized communities or people with chronic or hard to treat rare conditions, things like that, is that these programs are set up to serve these communities and these communities of patients, right? Like we know that the public assistant need is there, but private enterprise gets their fingers in there and they get their little piece on that, and everybody starts to go, oh, this is costing too much, so let's take some dollars out. Private enterprise is always going to keep getting their dollars. When you take dollars out of these systems, the people who get hurt are the people it was meant to serve in the first place. It is necessarily an act against health equity, furthers disparities, to take dollars out of these systems rather than making sure that doing the regulatory work, doing the legwork and the reform work to make sure they flow better toward that targeted and intended impact.
I think that's an important point. We look at often healthcare as a zero sum.
Mhm.
If I have a new product, it's got to come out at zero sum increased cost. If I have, a new service or something, it's got to fit within, a zero sum increase cost. And yet, as you indicated, if we take those dollars out with that kind of fiscal pressure, the give has to be someplace. And often the give is with patient populations. And with Medicaid, for example, we have, a reliance on Medicaid for our pediatric populations. Some of our chronic rare diseases have, 50, 60% of peds in Medicaid. And so Medicaid is an important payer. And so as that cost shifting goes around, those are the patients that are going to be harmed over the long haul.
Right. And especially if we look at reforms that we're seeing in various states on their Medicaid programs to include more coverage, more innovative coverage for
Mhm.
rare conditions, for chronic illnesses, for underserved populations, that becomes an even bigger deal. Those programs will not be able to absorb additional costs if we're already taking dollars out.
Right, right. Kelsey, if you could go to the next slide, and we're actually just going to move through the slides. The slides will go out to participants after the workshop. And so you'll be able to see some of the slides in the background. But let's go back to the Maryland one. Jen, as I've have been interacting with policymakers in Maryland as well as staff, which is, I think, a really interesting dynamic in Maryland. There was an openness towards discussing solutions beyond just a UPL, and looking at ways that we could reduce patient out-of-pockets more directly. I had a couple of these conversations with committee staff, and they were very open. And that's not necessarily the case in every state we interact in.
Right.
So my question is, how can we better uh, communicate that and find those types of champions, particularly given in some of the states, for example, like Virginia, where support for PDAB is kind of baked in on a political level. And yet, in a state like Maryland, we are finding an openness and willingness to have a conversation. And how do we better target those and find those opportunities?
Well, I think there's some base level education that has to happen, outreach and education, and it's really kind of hard. We make assumptions, especially as advocates who are kind of steeped into the policy pieces here, and really kind of understanding the ecosystem, how dollars flow, things like that. We assume that these folks know the same things, and they don't. They
Right.
really, really don't. Like the level of aha light bulb moments that go off around this is kind of crazy. We actually just saw one yesterday in Oregon, where they voted to reset their affordability review process in
Right.
part because we got enough light bulbs to go out, right? Like to turn on and go, wait, wait, wait. We didn't know that this might have these kind of impacts, and we need to understand that better. We also need to understand what affordability actually means on a population level as well as an individual level. So the light bulbs started to go off. And I think that Maryland's legislators are really kind of open to that. I think that the executive director for the Maryland PDAB is very, very open to that. I think there are select members on the Maryland PDAB that are open to that. There are also members on the Maryland PDAB that are making bad faith arguments in opposition. And you've got to, when you're engaging these boards in particular, not just the legislators that have got to get themselves engaged, but the boards themselves, is you've got to identify where's the voice of influence. So in Maryland, Jerry Anderson is an economist that they've got on there, and he's made some ridiculously bad faith arguments. Sitting there go, okay, medications are like bread. If you reduce the cost of bread, more people have bread. That's not how medications work. That's
Right.
not how the flow of dollars work. That's not what access actually looks like and defines itself, especially in the ecosystem that we have now. Also, I don't know about y'all, but I don't grow my medication in my kitchen. Like that's not a thing. So, and it's quite offensive if on the patient level. So trying target that language in a way that says, no, this issue is more complicated than what you're talking about is really one of those places, I think, Mike, when you're talking about that lean in and education has to happen.
I think that's an important point that you just made. I spent some time with a pharmacist here in Virginia this legislative session, and he was explaining to me, the system of, fulfillment, chargebacks, the kind of how they get paid. And, even after the medicine has been dispensed and out the door, that they still don't know how much they're going to get paid until they finally do get paid, which is very different than, as you just described, trying to compare it to bread or trying to compare it to another consumer good, where you actually pay the cash for it, you walk out with the product, it's been paid for. And yet with, of course, our reimbursement system with chargebacks and rebates and all the other things that are built in, some of them to give specific benefits to certain purchasers, whether it's Medicaid and now Medicare, the purchasing is far more complex than many people try to portray it. And, that simplified kind of, oh, well, this will benefit society as a whole may not necessarily apply after you start determining what those economic forces are in the pharmaceutical marketplace, which so many people don't seem to understand. So I think that was a really important point that you brought out, is that we're fundamentally dealing with something that doesn't fit into the models that most policymakers are going to want to fall back into to describe what's going on here.
Well, and I love that you have Illinois listed here because the Illinois Biosciences Association, or Illinois Bio, did a great job. The executive director there, John Conrad, did a great job at pulling in all these different kind of stakeholders in the supply chain to explain to the bill sponsor and the committee chair, like, why a PDAB or UPL specifically doesn't work. And they brought in distributors, they brought in pharmacists. Like, there's really good kind of stakeholder engagement in Illinois. And so the bill sponsor turned around. Mike, you're gonna laugh. The bill sponsor turned around and said, well, why can't you just set up an Illinois specific distribution system? That's not how this works, right? Like that
Exactly.
is an enormous amount of money, because that was like the policymaker was finally made to understand how these things actually flow, and then kind of threw stuff out there. She also said that, we understand that in making an omelet, there's going to be a few broken eggs, not, this isn't going to necessarily serve everybody and everything else. And I about lost my stuff. This was in a private meeting. There's no recording. I about lost my snot though, because when we're talking about patients losing access to care, that's somebody dying. And that's not an acceptable broken egg.
Right. Exactly. Next slide, can you see? So, Jen, you had brought up the Oregon PDAB at the front end of our conversation. And, as I look at the landscape and I start thinking about this, I wanted to get your take as well on, is it because we are better educating policymakers, or there's something else in the back of my mind, and that's the MFP coming for Medicare Part D and the potential for CMS negotiated price, and potentially states just adopting those and moving forward in that direction. Do you think that there is a sense in kind of the policy marketplace of, hey, let's kind of wait and see what CMS does here, and maybe piggyback onto that in terms of, some of the pauses that we're seeing occur in some of the states?
I think there's some of that. So Maryland provides an excellent example on that, because they're talking about adopting MFP and then kind of running with that as a model. And part of what we've got in Oregon's talked a little bit about that too, but they're not entirely sure how to do that for drugs that aren't listed for an MFP, right? So there's that, and there's a dynamic there. CMS just came out with projected health spending over the next 10 years. And one of the things that's noted at the end, it's a third paragraph, and Mike, I can make sure that you guys have this document to share from CMS, is that it is projected that certain government spending is going to go down over prescription medications, retail medications, but that consumer costs are going to go up as a result
I thought
because
that was pretty interesting. Yes.
because of the MFP. And that is the estimation there. And it's really kind of crazy that that's something that folks are championing. As we look at this under the lens of let's save patients money, like it does not make any damn sense. Yet here we are.
Right. That's, that's a really interesting thing to look at. And I was just reading the Millman study on this as well, where they noted that the costs closer to retail will begin to rise with some of the products as well in the Millman analysis. And so it does create an interesting dynamic in terms of, as you described earlier, the flow of money and how that flow of money in the life sciences distribution system actually can change what comes out of the patient out of pocket.
Right. Okay.
So thank you for that. Again, a summary of a final couple of states, just to note that, in some of those states, many organizations, as Jen, you had mentioned, are very involved. And I know we as an organization are already beginning to reach out and schedule our visits this fall in advance of 2025 to begin with those educational efforts. So some of this, I think, is really timely for us as a community to begin to look at and say, you know what, this is the kind of thing where we're going to need some running room to get in and start having those kinds of discussions. As you had mentioned, maybe opening up some eyes to say, you know what, PDAB might not be the panacea that we thought it was. Let's start focusing on patient out-of-pocket costs and where we can actually make a difference in patients and what they pay versus, this kind of experimental mechanism. And so, that's something I wanted to shift gears towards so that we can talk a little bit about that for the balance of our time together.
Yeah.
Kelsey, could you go to the next slide? So one more slide. I think, Jen, you had mentioned this, and I think it's really interesting because, as I talk to a lot of folks as we're lobbying and advocating as well, we hear a lot of the challenges of patients and what they pay for drugs. In fact, I will be standing in line with someone who's testifying, and as soon as they testify, they start talking about their benefit design and how they have high out-of-pocket costs because their product's been placed in a certain specialty tier or high cost tier where there's maybe a 35% copay or a 45% copay. And that's being used as a kind of a bellwether for drug pricing. And so I think there are some opportunities here to talk about, benefit design and the potential that we could actually look at benefit design that could serve the needs of these patients versus, a PDAB potentially disrupting the access system through the payment and the flow of dollars, and maybe doing something that really could be constructive here. I wanted to get some of your thoughts and what some of your thinking might be on that as well.
Well, I think we're very much on the same page, Mike, and I don't think that that's particularly surprising because we come from the same space, and we've got some shared background there, right? So as these PDABs do these affordability reviews, one of the things they don't talk about is benefit design. When Colorado, for example, in their survey, they talk about cost, but they don't define cost. We know that it costs us as patients dollars to deal with dollars, time, energy, like health, to deal with things like utilization management, prior authorization, step therapy, and things like that. And we also know that that's a giant piece of what people think about when they say cost, when patients think
Right,
about cost. They're not just
right,
talking about that out of pocket piece, that copay. Certainly, it's at the forefront of the mind, but it's not the only thing. And so, when we're approaching legislators about benefit design issues or PBM reform or anything else like that, I think it's really kind of cool to lead in with that and then kind of follow up talking about problems with PDABs and AUPL and how they're not serving those means. Indeed, they might be serving against them. Because here's the sheer reality. You cannot bribe a bully into not bullying. And that's what a PDAB is ultimately designed to try and do, is to get these PBMs to behave a little bit differently if we give them just a little bit more money. That's not going to be the case. We know that's not going to be the case. So,
well, we see that with copay accumulators. We see it with, alternative funding programs. We see it with a lot of mechanisms that the plans and the PBMs utilize to, again, contribute to the bottom line versus, focusing on patient access.
right. And well, and defining out that access. And I think as we look at reform efforts and these other pieces that we're all kind of engaged on differently, we have other priorities, right? Especially in dealing with benefit design and patient protections around those things. I think that that is a prime opportunity to talk about how a PDAB and a UPL would undermine those efforts. Piggyback those things. Lead with the thing that's most important to you. Absolutely. That's the thing that you like. You want to make sure that Medicaid's expanding coverage for the GLP-1s, right? Like that's great. Like do that. There's a lot of benefits.
Right,
And
right,
make sure that you're protecting that line as well. So when you turn around and you go, hey, these funding mechanisms matter. These funding mechanisms protect patients. These funding mechanisms make sure that we continue to have access to care. The funding mechanism is not the problem. The benefit design is. So
right.
don't go mess around with a PDAB. Like don't like that idea is kind of half-baked and not there. Focus on protecting patients. At the end of the day, you're going to end up reducing cost to system and cost to patients by doing that.
Right, right. Thank you for that. I mean, that's something that I think for the rare community would make an enormous immediate impact
Mhm.
is, how drugs are evaluated, placed in various tiers, how patients then can access those, and, potentially how benefit design could bring down costs for patients. I know I've had a number of conversations with the Medicaid folks in Arizona. And Arizona's done a number of innovative things, not necessarily perfect, but innovative with risk pooling and trying to use risk pooling and risk sharing to broaden their access within the state. And so there are some creative areas I think that we could move forward that would allow us to look at things that are actually working and potentially could actually make immediate benefit versus something that's experimental and downstream could disrupt that rare disease medicine or that chronic care disease medicine or that specialty care medicine.
Absolutely. And I think one of the things that folks get really frustrated with is they're looking at things like high deductible plans, right? At the end of the day, it's still insurance. And the precipice, the reason behind the ACA and its expansion of coverage of everyone was spreading out that risk. 100%. You are absolutely paying for somebody else's health condition. That's how insurance pools work. So why are we complaining about that?
Right. And let's find more ways to expand the pool.
Right.
Kelsey, could you go to the next slide, please? So, we were looking at and thinking about the table, so to speak, and strategically where we've been this year over the past 12 months, states that have been active this year. And now we're trying to think about states that could be active in the coming years. There are, Kelsey, and I'm just looking at our chart, we're even missing a couple states that had PDAB initiatives this year that didn't come up the light blue there, like Virginia. But Jen, as we look at the map and we look at all the states in play, for 2025. I think one of the biggest things that for me that comes to mind is that it's a lot of resources to get into this number of states and to find the right people to have the right conversations with, the right people to educate. And so that's kind of an enormous task, particularly given that we know that PDAB legislation could proliferate to more states in 2025. What would be some of your thinking behind how strategically, a patient community can really look at the breadth of the map and effectively target this kind of territory? I mean, it's a big undertaking.
It it is, and I think that part of what we've got to do well as we look at our own health conditions and we look at who our partners have been in these various states. I noticed that Laura Bonnell has been in the attendance group here, and she's just been fabulous. She's all over the place trying to do that kind of work as well. I think that we've got to develop our relationships on the state level, and explaining to those state-based organizations and community groups, patient groups, why this is important. I think that the roadmap from this year is going to duplicate itself in 2025 in states where we essentially defeated PDABs. I will say that everybody needs to take a big moment, big deep breath, and go, "Hey, there were no new PDABs in this state legislative session yet." And there's very few states that are left considering new PDAB legislation. So that is a testament to the work that has already been done. And I think there's a lot of repeating those models that we're going to see in terms of effective education, outreach, things like that. But in terms of our own capacity to continue doing that as advocates, I think we've got to get really good with asking for help and deciding that we can't be everything to everyone. So, for example, RAAP has excellent presence in Virginia, in part because you guys live there, right?
Yeah, yeah.
CAN doesn't need to lead the outreach in Virginia, right? We're going to look to you guys to lead that and to support that. But it's not our job to lead that because we don't have the same strength of presence there. Brandon McSada is the CEO for ADAP Advocacy Association, sister organization to CAN. He lives in Connecticut. Absolutely had him leading up some of that work there. And I said, how can CAN support that? And we made progress, right? The bill didn't pass. Legislative was over. Identifying who your key partners are in an area and supporting them, like navigating comfortably and clearly who's going to lead and who's going to support for various things is really kind of important. So talking to legislators is one set of skills. Talking to the press is another set of skills. Talking to community is another set of skills. Talking to the boards and engaging on boards where they already exist is another set of skills. Identify those things comfortably and ask for help where you need it. Make sure that you don't have to be the folks in charge, right?
Right. I think that's really important. And you had mentioned we're coming into mid-year 2024, and we haven't had new PDAB legislation passed this year. And that is a huge accomplishment. Some feedback that I got from policymakers in a few states was in large part because during the 2024 legislative session, patients showed up and patients started talking about the impact to the reimbursement system, the impact of patient access, the impact to the ability to be able to find a product when you're being treated out of state and who pays for that. I mean, there were a lot of issues that patients brought up this year that I don't think that PDAB proponents had to face in years past. And that is large part because we had really, really strong patient advocates jump in and literally jump in front of the PDAB train. I know in a number of states that advocacy got involved in, that really was what policymakers thought they were on the fast track this year.
Oh yeah. Well, and
And
I think it's important to identify across the states where you're seeing PDAB proponents where there's similarities between them. For example, in Illinois and Michigan, we know, and even in Maryland, we know that the local NAACP chapter is supporting the PDAB. And I don't think that that's malicious. I think they don't know what they're dealing with. And so think about where there are opportunities and relationships already with those proponents of PDABs to maybe educate them as well, not just the legislators, but the folks making noise about it.
And I think that's a fair assessment. As I've talked to some of the organizations that have been supporting PDAB in the states that we've been active and where I've had an opportunity to talk to them, Jen, I do hear that they don't necessarily understand how they will work, but because they believe in lowering pharmaceutical costs, they naturally just signed on board. And so, there is a desire, I think, to look at ways to lower patient out-of-pocket costs. And it is that education, I think, is super important. And to look at where we can find those who are on the other side and willing to talk to us will be critical between now and January when the next legislative sessions run into gear.
Absolutely. And at the end of the day, in a bunch of these states, we already have relationships with those folks. It's causing us a bit of heartburn in the actual legislative session, right? So get ahead of that.
Mhm.
Like identify the folks that you saw there and go, hey, we've got a relationship well beyond this. We
And
agree on ultimate goals. So let's have a conversation.
I think that that's really critical. And you'll see in the next couple of slides, that's really our message, I think, for participants today is that now's the time to engage. Now's the time to have those conversations. Now's the time to look for areas that you can work together. Because there are a number of areas that I know those who support PDABs would be willing to work on with us and see if there's some common ground that we can find. So we do have a runway now to start working through these issues and to start preparing for 2025. And so I think that collectively, the engagement time is now. I know at RAAP, we're going through a strategic process this summer to help flesh out some of the key messages. Like we had talked about earlier, Jen, how do we shift gears and talk about true patient out-of-pocket costs? How do we look at ways that we can affect true patient out-of-pocket costs in a way that preserves access, that continues to allow for innovation to enter the marketplace, and to make sure that we're laying good foundations for further policymaking. But by Labor Day, we intend to be fully on the ground in those states where we think that we will be able to make a difference, to have those kinds of discussions. And I think that's really critical, because we have an opportunity to get hit ahead of the 8 ball a little bit over the next couple of months.
Well, I'm
And
gonna promise folks engaged on this now. If you do out of session investment in having these conversations, doing the education piece, and ultimately, I found that if you are effectively educating on this, that the reality of these things, then the issue gets dropped. So if you make that investment now, then there's not going to be wildfires that stretch your capacity in the legislative session. You can get ahead of it.
I agree. Kelsey, could you go to the next slide, please? So I wanted to just share with everybody a little bit about what we're working on at RAAP. And then, Jen, I really would love to hear more about, what you're working on with CAN, some of the direction that you're taking. And, I really look forward to working with you through this summer and into the fall as we prepare for 2025. We are currently engaged on building those advocacy tools from a rare perspective, so that we can have, ready information that is good, that can be understood by policymakers and, lay audiences, and making sure that our toolkit is filled. Also, we are going to be at the Legislative Summit at NCSL in August. I think that's really important. Organizations like our organizations, we don't have a lot of staff, and we can't necessarily be in every single state. And yet we have some of these organizations that come together throughout the summer and into the fall, like NCSL, NBCSL, the National Conference of State Governments, and others, where we can actually spend a lot of quality time with policymakers. And I would urge advocates to start looking at those types of meetings where you can get meetings with a lot of state delegations and have those kind of preliminary discussions that can lead to discussions back in their district or in their state. And so, RAAP, we're going to be engaging in those later this summer. And we also have what's called a learning hub at the NCSL Summit, where we will be talking about patient access and the importance of understanding patient out-of-pocket costs as a preliminary to pushing back on PDAB into the fall and into the legislative sessions. So really look smart at those types of gatherings. Many states have, for example, legislative meetings or events with their local insurance organizations or doctors organizations where lawmakers come together and interact with folks at those types of meetings so that you can really get a bigger bang for the time that you can spend and get more mileage from those interactions. What's really interesting to me is when you are at a meeting like NCSL or ALEC or NBCSL, it's kind of neutral ground, and policymakers are a little bit more willing to open up as you're talking in a more casual environment without the calendar ticking off, without, floor or committee action, all those types of things. And they're a little bit more willing to actually talk some substance. And so utilize this summer to target those types of bigger events where people are pulled together. And then, of course, in 2025, we have a pretty robust plan. And like you said, Jen, we're going to try and really lean into our strengths. What are the states where we can get some mileage, where we have relationships? And then what are the states where we can leverage the strengths of others and really be supportive and not necessarily have to be in the lead in every state, but be a support and be a help and get our rare patients there when they need to be there, so that we can support those efforts as well as take the lead in states where we have maybe a more robust presence. So there's a lot going on at RAAP to prepare for 2025. But Jen, I would love to hear some of the work that you're doing, because I understand and know that a lot of us are on shoestrings and we can't be everything to everybody. And so our focus on PDAB sometimes comes with competing interests and competing things that we can and can't do. So
I'm so annoyed by PDABs, guys. Like the fact that this has become a thing for me is really annoying, right? Like I think there's room that we get to say I am annoyed by this thing. It's not what I actually want to be dealing with, right? And it's stretching capacity. It's costing us dollars. There's it in terms of limiting our ability to do the work that we feel is most important, right? This is not the policy issue I want to fight, but it's the policy issue I have to fight, because
right.
otherwise I'm not going to be able to have the programming and infrastructure in place to even worry about the other policy issues. So we've got to figure out how to do a little bit of everything here and there. So one of the things that Ken has been trying to working to put together, and we've got some announcements coming up, is a summit among patient advocacy organizations that are worried about this, who have strong state presence. And we're gonna work through a lot of stuff, and we're gonna approach folks that aren't necessarily entirely convinced in the same lens that perhaps Ken is. I know that it is my intention in about 2 weeks, Mike, to reach out to RAAP and to ask y'all to come present some information there. But ultimately, the end goal of that is that we're going to do a strategic planning session with our partners in advocacy about who does what best where and how to make sure that we are extending each other's capacity so we can focus on the policy issues that are most important to us. Because PDABs certainly aren't it. They're just really annoying. Access is my primary concern, right? PDABs do nothing but harm access. I don't want to just have to guard against harms. I want to deal with the issues that we're dealing with today and actually move the issue forward. To that end, one of the things that we've recently developed and just kind of put out, and it's in front of you now on the slide deck, is a leave behind for certain legislators, but also a really kind of simplified infographic for PDABs, the actual board members, or even community members to understand this. So what you've got going on here is we've got an example of what a UPL does to the 340B rebate value, which is very important in terms of public health. It'll also get hospitals on board, which I don't often find myself aligned with them, but it's something that even on 340B is an issue, but this is something that speaks their language. So, and having a hospital system supporting our position is a big deal, right? That's a big deal. Is look at the potential for advocacy partnerships that might feel a little counterintuitive, but on this one thing they can agree, right?
Right,
So
right.
that's part of what we've got going on there. You also notice at the bottom of the infographic, we outline, and we're using the AIDS drug assistance programs kind of as a very transparent opportunity and well-monitored opportunity about where these dollars might have an impact. So we talked about Oregon very specifically. The Oregon AIDS Drug Assistance Program gets about 60% of its budgetary funding from 340B rebates, and it puts 0 state dollars in there. So one of our pieces of advocacy in Oregon was working with Cascade AIDS Project to explain the issue on how this might adversely affect the budget for the state's AIDS Drug Assistance Program. This is only one part of the problem, right? Through the 340B piece. And so what they had to do is go back to regulators, the health department that manages all that, and go, we're going to need some backfill dollars because we're going to lose money if a UPL is implemented. And that caused a big pause because then we followed up and said that doesn't solve the entire problem because federally qualified health centers are also reliant. We just don't know how reliant. So now you got to take another step. What about Medicaid? You got to take another step. And so what happened yesterday is this level of education got the Oregon PDAB to go, we don't actually know what we're doing. We've got to stop. We've got to really put this giant pause and reset things because this is information we just didn't know. So developing tools like this that are real easy to grab, that are real tangible for folks is part of where we're spending some of this time.
I think that's terrific. And it is interesting to me. And again, I'll just kind of reflect on what we talked about earlier is that when advocates do get involved and bring out these real world challenges with an experimental program like PDAB, that you know, some of our policymakers do pause and think about it. And that really is, I think, the power of our message is to come at this from those different angles and talk about the rare patient seeking care in Medicaid, talk about the 340B program or, you know, the Title II program, the Ryan White Care Act and how it impacts that, whether it's in the ADAP or, you know, the other aspects of the program. Because I really think, like you had mentioned early on, and it's still kind of sticking with me, is that this is not a loaf of bread. We are not making a discrete purchase. We are actually making investments often in the care of those patients that have been over time and not through anybody's fault today, probably, but over time, additional services, program elements, additional parts of the care network have been, you know, kind of put in with the value of the pharmaceutical.
Right. That's
And
how
it's
fun
just
it.
reality. Yeah.
So, and I think and so at the top, and this is part of where we get to integrate this stuff, and I think we've got a really good opportunity in Illinois coming up. As we talk about federal ending the HIV epidemic here, that is a policy issue. That is a stance that states have adopted individually as well. And so Governor Pritzker just did a press conference on getting to zero, which means that as Illinois goes into its session, we're going to be educating the governor a bit more on how a PDAB would threaten those goals.
Right.
Look for those opportunities where you've got broader, and this is what I mean, but look at those broader policy pieces that are more important to you, that are absolutely where you want to be doing the work, and where a PDAB is going to reduce the value of that.
Right. That is really good advice. Kelsey, you want to go to the next slide for us? So we've actually talked a lot more about being proactive in 2025. And I know, for example, at RAAP, we are building our patient engagement caucus, which our goal at the kind of our end goal, Jen, is to have at least 2 patients in every state. Now, that doesn't mean that immediately that we do. We are still working on it, and we have a wonderful patient engagement caucus. We call it at RAAP, or the PEC. And those patients are in many of the states we've discussed today. We do have patients in states that haven't seen PDAB yet. And so preparing them has become a real focus of some of our efforts through our meetings. When we get them together, we talk about it. We've been sharing materials. We've got materials out for review right now. And so to build that knowledge level, but to have at least 2 RAAP trained, involved patients in every state is our end goal of our PEC, so that we can start doing this. I think, like you, Jen, this issue steals all the oxygen from really doing the things we want to do, which is to create a better access environment for rare patients. And so our goal is also to be able to shift over time past the PDAB and into areas where we can provide and build sustainable access through policy initiatives and things that really can benefit patients, as well as the states, the programs, et cetera. So that's really important. And I know CAN works a lot with capacity building and with identifying patients and working to build that capacity at the state level. And I would wonder what your thoughts are about, again, building out those networks and areas that you think that organizations really should consider.
Well, I'll say that Ken has a little bit of a cheat sheet that folks outside of HIV don't typically have, and that is the Ryan White federal program,
They do.
right?
Yes.
For folks unfamiliar with it, Ryan White mandates a planning council in every state that receives Ryan White dollars, which is all of them, and that planning council has to include patients. So we've got a ready engagement piece. It's part of why, like, HIV is our mission, but it's part of why we've been so well situated to engage in the states. Indeed, in October, I'm going up to Minnesota to do a presentation on PDABs to the Planning Council, so that they're prepared to engage. Right? Like, you've got a state endorsed body that's going to engage with another state endorsed body. That's really an astounding opportunity. One of the things that I'm working on around this summit opportunity that we're going to talk about is how to develop outside of that space. That might look like going to a city council meeting. It looks like getting uncomfortable. It looks like not looking at the spaces that you're already in. It looks like identifying other patient advocacy organizations and seeing what they're up to, and really just investing in each other. At the end of the day, while we are very focused as advocacy organizations on the specific health condition and health condition areas that we represent, this is still an ecosystem of care. What one group does well, we can learn from. We have to invest in each other. If our drug is not going to come up at a PDAB, we still need to be engaged. And that's how you create that investment. That's how you build that network around it. Our communities are filled with patients. All of us are. you've got to make that investment. So,
I love that you came back to the councils
oh yeah,
that required by Ryan White. Um, because in the rare disease community, there has been a huge push over the last 5 years to require states through state mandates, not federal, but through state work, to organize RDACs, Rare Disease Advisory Councils. The challenge for us has been, for example, in Colorado or other states, is that the RDACs are not necessarily engaged by the PDAB. And so we have been working with some technical language that we have been offering. And of course, as you said, Jen, the PDAB issue just derails or sucks the oxygen out of a lot of these things we really want to do proactively. But basically, that would require state decision making for rare disease medicines to empanel patients and specialists as voting members for those drugs that are for rare diseases. So we had been working on that, but what an opportunity, that's lost in states that are moving forward with PDABs or have PDABs in place that are not linked to their RDAC and not
right.
utilizing those patient and specialist resources that are already on the RDAC and honestly don't have a remit to actually engage with the PDAB. And that's all that's needed. So that's
Well,
been an
and
area that we've been focused on as well.
we almost had an opportunity in Colorado this year before things got watered down, and because a particular manufacturer decided they were going to go off the reservation. Um, the sponsor for a bit of the PDAB reform was very interested because she was a co-sponsor for the RDAC in the legislation that authorized the RDAC. She was very interested in requiring the PDAB to consult with the RDAC before making any decisions. That didn't make it into legislation this year, but that doesn't mean it can't next year. And RDACs are in about 30 states, and there continues to be more growth in that. I think that interagency coordination and intergovernmental panel coordination requirements are quite useful in terms of really kind of educating the policymakers, or if we can't stop the legislation, and make sure the board is extraordinarily well informed so that maybe in the ideal they go back and tell the legislature they can't do what they think they were going to do. So it's there's different ways. We've got to look at this as both pre-legislation and post-legislation, right? Minnesota, for example, requires, and this wasn't required in Colorado, but Minnesota's legislation requires that the PDAB engage with the existing public health agencies, which is really useful. Making sure that there is cross expertise, cross subject matter expertise is really important. These insurance committees which is where these are typically housed, don't have an understanding about the actual healthcare space. They only know about insurance, and even that's a little bit. So that's broadening the expertise engaged is an extraordinary tool.
And that's really important. And I like that you used Minnesota as your example because, a member of the RDAC is impaneled and the PDAB in Minnesota. And, it just makes sense to utilize those patient advocates and specialists and their expertise in their diseases. So critical. And you know what, Jen, I could talk to you all afternoon about these issues. And it looks like we've come up at the top of the hour, and we're still kind of really just scratching the surface on 2025. I think what's really important, and I would really like to stress here, is that both CAN and RAAP are engaged in strategic discussions to prepare. And I think that preparation is something that really allows us to pivot more proactively on PDABs. And my hope is, and I think Jen, yours probably is fairly similar, is that we can use PDAB as a pivot and a springboard to really point out how flawed PDABs are, and then pivot and spring into patient access and look at benefit design, look at how we can be more accountable for out-of-pocket costs, look at how we can then focus more on the patient and really bring forward better, more innovative policies. And so, I would really welcome the opportunity to work with CAN this summer. And Jen, I would love some of your feedback on our strategic direction. You hit on a couple of things that were important to me, and I think to RAAP members, is that, there's going to come a point where people are oh, I've got the rare community all happy. We're going to exempt their products. We're going to do this. We're going to, whatever it might be. And as you said, the problem is still the problem for HIV patients. It's still the problem for other patients with chronic serious illnesses that get targeted by the PDAB and a UPL. And so even if we take care of it from a rare disease patient perspective, it's still a patient problem. And so those are some of the things that we're wrestling through this summer, is to make sure that we're prepared so that we are, really a good partner moving forward and engaged at that level, so that we can really hopefully be a positive influence in PDAB. Jen, I'll toss it over for you. Any closing comments or thoughts, and then we'll adjourn.
Well, so we approached this in Colorado as we were really kind of developing our PDAB engagement. And one of the things that I talked to a particular manufacturer about, because they said, we're not worried about 6 protected classes, right? And I said, you really should be. And they go, why? That's not our disease state. That's not what our therapeutics treat. And I said, how many of your patients are on antidepressants?
Mhm.
Why do you care about that? How many of your patients are on antidepressants? And they said, all of them. At the intersection of rare disease, or even HIV or any other particular health condition, we have other health conditions that we've got to worry about, which means, yes, this might be the most pressing health condition that I'm worried about. It's the space that I'm engaged in. This is what I do for a living because I love it, because I'm supporting people. But it's not the only space in which our communities also have health condition problems, who have access problems, right? Somebody living with HIV and the comorbidity of diabetes, for example, diabetes is going to kill them a lot faster than HIV, but HIV is where the support is. So
Right.
making sure that we are looking at patients as whole human beings, not just the health conditions that we represent, is really important as we engage with PDABs. That is my cap.
Well, thank you for that. And thank you for your insights today. I really enjoyed being able to just talk back and forth and talk about some of these issues. And I want to thank all those who took time out of a hot summer Thursday afternoon to join us. As always, the slides will circulate after the workshop, and you'll be able to find the workshop on our website at the rareaccessactionproject.org. And so you'll be able to go there and be able to refer to the workshop. It will provide the follow-up there. And as always, if you have any questions, please reach out to the RAAP team. We are always happy to help you find answers or work through issues. And again, thank you, Jen Laws, for participating with us. We look forward to working with you throughout this year.
Thanks, Mike.